الجلسة الأخيرة إن شاء الله. يسعدنا جدا إن احنا النهاردة نبقى مجموعين ومجتمعين إلى هذا اللقاء العلمي الجبار. موضوع High Risk Pregnancy and Obstetric Hemorrhage. The nightmare لكل الأوبستريشنز. The placenta, أكريتا، إنكريتا، بريكريتا، حنكريتا، فنكريتا. مش كده فيه؟ طبعا الأول بقدم أخي وصديقي وعزيزي وأستاذنا الجميل الأستاذ الدكتور وليد البسيوني، أستاذ أمراض النساء والتوليد بكلية طب جامعة عين شمس، وهو ضرائد البلاسينتا أكريتا أو باس سيرجري إن عين شمس يونيفرسيتي أند إيجيبت. الأستاذ الدكتور وليد البسيوني هيكلمنا على باس disorder to conserve or not. This is not the question. This is the question. Not the
ده اللي هنشوفه يا بيه دلوقتي ان شاء الله.
not to conserve. طبعا معانا الاستاذ الدكتور احمد حسين والاستاذ الدكتور سعد الجيلاني والاستاذ الدكتوره نوره يسري. نشرفنا جدا يعني هذه المجموعه الطيبه، وليبدا استاذنا الفاضل الاستاذ الدكتور وليد البسيوني في المحاضره بتاعته.
It's really a pleasure to be present together in our valuable conference that every year proves that Ain Shams has a leading role together with the other significant colleges in committee, and thank our dear Professor Dr. Subhi Aboulouz, our godfather and our leading surgeon in this difficult situations, who held our hands from the start in those difficult conditions. Professor Dr. Fikriya Salama, my direct boss, and Professor Dr. Muhammad Khandil. To conserve or not to conserve, well, actually this is not the question now. Why? Because placenta accreta, or the placenta accreta spectrum, it's a very old disease. It's been present over 100 years or even more than that. It's actually now what we call the bête noire. What do we mean by the bête noire? It's the black beast. It's the black beast. Previously, when we used to deliver vaginally frequently, the occipito-posterior position was the bête noire of obstetrics. Now, when the rate of cesarean sections increased, so the bête noire of obstetrics is the placenta accreta spectrum. The current prevailing hypothesis is that a defect of the endometrium, myometrial interface, typically at the site of the prior hysterotomy or cesarean section, leads to a failure of normal decidualization in the corresponding uterine area. This allows extravillous trophoblastic infiltration and villous tissue to develop deeply within the myometrium. And hence, the placenta accreta spectrum is not a malignancy. And hence, it's a matter of a vascular malformation that whenever you're capable of controlling, you could control the condition. As I told you, the placenta accreta, this is the first paper to be written on a case of placenta accreta in the year 1926, nearly 100 years ago. And it was a rare condition, which continued to be a rare condition till the end of the 20th century. In the beginning of the 21st century, the cases started to increase dramatically due to the increase in the number of the cesarean sections. And hence, the experience started to increase over the past 15 to 20 years. So the number of cases increased markedly in the last 2 decades. The incidence varies markedly according to the number of cesarean sections in different countries. So in countries where the cesarean section rate, we're speaking about 10 to 15%, differs in a country as ours, where the cesarean section rate really reaches 80%. So the incidence varies from 1 in 2,510 women up to 101 in 150, and this in a study published by my dear Professor Saad al-Jilani in the year 2019. The rate of cesarean deliveries plays an important factor in this incidence. the radical surgery was a suitable method for their treatment due to the scarcity of the condition. And hence, when they suffered or they met just 10 cases per year, the radical surgery and to do a hysterectomy was the proper option. But after the increase in the expertise, everybody tried to decrease the rate of radical surgery and try to go towards conservation, but with the risks. And hence, you're going to find lots of papers speaking about conservative management. This is one of the largest studies, the PACRETA study. It's done on 510,000 deliveries. They found more than 150 cases of placenta accreta, and they compared between radical surgery and conservative surgery in these cases, and they came with a conclusion that conservative surgery is an effective procedure, and even that the blood loss and the blood transfusion in these cases in which had conservation, against most of us know that conservation may lose much more blood, but this study proved that blood loss in the conservation group was less, and those patients received less blood units. On the other hand, you're going to find lots and lots of measures of conservation that have been adopted throughout different countries. So in Taiwan, they adopted a single method or a one-step conservative measure, and they called it the Moscas. And you're going to find lots and lots of measures of conservation that have been published over the last couple of years. For example, this is one of our Al-Asr Al-Aini. They put a method of conservation, and they're a very nice group. I know them personally, and I know that they are very potent surgeons for the conservation management of the placenta accreta, adopting a specific method of treatment. So questions and barriers remain, but are surmountable. They could be overcome, yes. But again, to conserve or not to conserve, this is not our question now. Why? Because the conservative management of the placenta accreta carries various forms, and when done by wrong hands, led to the morbidity and mortality of the patients. This paper is very important to tell us that the maternal death related to placenta accreta spectrum are preventable. And this is a very important paper in the medico-legal part, because when a patient dies from placenta accreta spectrum because of excessive blood loss, and you are litigated and you go to the lawyer, he's going to tell you that you have to bring papers that tell that this patient mortality rate is high. If the other lawyer brings this paper, you're going to find yourself in a very bad situation, because it says that all maternal death related to placenta accreta spectrum were potentially preventable, and nearly 80% of the cases were avoidable by low to moderate complexity interventions. And hence, the trial of conservations in wrong hands led to major complications and mortality of the patients. Personally, I have met 3 to 4 cases in the last couple of months where they tried to do conservation and ended by the death of the patient. The mortality rate is around 8 to 9%, but unfortunately, I'm going to show you a paper that speaks about, I'm going to just show you this paper and then going to go back, the management of unexpected placenta accreta spectrum cases in resource-poor settings. This paper did a study on 28 patients where they accidentally discovered that this patient was placenta accreta during the surgery in Taiwan and in Colombia. And they put 4 lines of management for these patients, and they followed up the outcome of the patients. The first outcome, or the first management, was that the surgeon closed the patient when he discovered that she is placenta accreta and referred it to a tertiary place. The second outcome is he delivered the baby and closed the uterus on an intact placenta without trying to separate it. The third outcome is he tried to separate the placenta and left a part of the placenta in it. And the fourth part was when he did a supravaginal hysterectomy. Unfortunately, the last 2 parts, the mortality rate was nearly 80%. So he did this in 7 patients. 5 of the 7 patients died. So trial of intervention in a patient that you're not ready to led to the occurrence of major morbidity and mortality. So what should we do? First of all, we should establish multidisciplinary teams in the management of placenta accreta spectrum. And this is a well-known case. And actually, I know personally more than 12 or 15 teams throughout Egypt that are working on this condition, distributed upon Upper Egypt, Cairo, Giza, and the Delta. So the teams are present. The second thing is to disseminate the idea that this is not the routine cesarean section that should be operated upon by the ordinary obstetrician. Because when you try to manage this condition and you are not enough expert in this condition, this is going to lead to the morbidity and maybe the mortality of the condition. The proper diagnosis. What we are trying to implement, that just do a single ultrasound for the patient between 28 and 32 weeks. If you diagnose this patient with just a low-lying placenta, I don't ask you for extensive management or to say that the grade of the placenta, and my dear colleague Ahmed is going to speak a couple of moments later about the different grades of placenta accreta spectrum, and that the ultrasound may be some decisive in this and it maybe give us a wrong idea. So just an ultrasound that tells us that this is a placenta previa, please refer the patient to a multidisciplinary team to put the plan for the management of the patient. So it's just one ultrasound. So if it's difficult, why not put specific ultrasonographers in specific places in different governorates that perform an ultrasound for the patient who is suspected to be placenta previa from 28 to 32 weeks. And it's not that difficult. Even if you are over-diagnosing the patient, this is not bad. But under-diagnosing the cases and accidental discovery during the cesarean section, this is the major morbidity and mortality. So over Egypt, as I told you, we have I know personally in Aswan, in Ina, in Suhag, Asyut, in Minya, Cairo, we have more than 4 or 5 centers. We have in Dumyat, we have in Tanta, we have in Banha, we have in Alexandria. So actually, the teams are distributed all over the country. So the multidisciplinary teams are present. What we need to decrease the morbidity and mortality is just put a proper sonography to document the presence of placenta previa between 28 or 32 weeks, and then we're going to take the next step in the management of these cases. This is the recommendation of this paper, who worked on poor, undiagnosed placenta accreta spectrum in poor resource countries. The recommendations to the surgeons was always look for signs of placenta accreta spectrum in the anterior wall of the uterus in pregnant women with previous cesarean delivery. If there is a sign of PAS, avoid cutting through the placenta and extract the fetus through a fundal incision. Before such incision, call for help. Ask the hospital manager for a formal support mechanism in the obstetrical ward or during surgery. Train and easy, effective strategies to control pelvic bleeding as internal manual aortic compression. And this is a very successful measure that most of us overlook. Just compress the aorta until help comes. But of course, you have to have some form of help. One of my colleagues, he sent me once an ultrasound, and I told him it was a para 5 cesarean section, placenta previa centralis. The next call was 5 a.m. He opened the patient alone in an unequipped place, and he's calling for help. And this is not accepted. Once you diagnose that this patient is any form of placenta previa, I'm not telling you even it's a form of placenta accreta spectrum, please do not operate upon it except in proper situations. Prepare a plan for massive obstetric bleedings. Define additional personnel to support the initial response. Define a formal route for emergency transfer of pregnant women with intraoperative PAS finding. And this is a very important area. Establish a formal telehealth process for severe obstetrical emergencies. This is very important. If I could do a contact with someone, I'm going to tell him, we are not a tertiary hospital, we're a primary hospital. And if we find a case that's a placenta excreta spectrum, you have your team, the multidisciplinary team in your hospital, and we're going to show you a video of the case, and please tell us what to do. If you tell us to close with the patient, we're going to close with the patient. If you tell us we could operate upon the patient based on this video assessment, we can operate, and you're going to be with us through the video. Of course, this is not the typical, and this is not of the best maneuvers, but at least this could reduce the morbidity and mortality. So the telehealth method I think, is a very important method in where the primary and secondary hospitals could call the tertiary hospitals at any time and do a conference, a video conference, and tell them this is our condition. This is the screening and diagnosis management of the Canadian Society as regards placenta accreta spectrum disorders. The recommendations, I'm not going to go through them all, but just I'm going to emphasize that pregnant women with clinical risks of placenta accreta spectrum disorders and anterior placenta previa at 18 to 20 weeks, fetal anatomical ultrasound should be referred for specialist imaging to diagnose or exclude this disorder. Well, they recommend that at 18 to 20 weeks, if you suspect it, refer it. And I was in the UK in the year 2019. They were following up patients from 13 weeks up till the time of delivery. Actually, more than 50% of the cases, the placenta migrated and it was not a case of placenta accreta. But the suspicion made them follow it up from 13 weeks. Because this is difficult over here, I'm going to tell you from 28 to 32 weeks, put the line of management. Women with a diagnosis of placenta accreta spectrum disorder should be referred to a regional center dedicated to the interdisciplinary management of this condition. And then you're going to put protocol-based interdisciplinary care and antenatal management according to the regional center you're going to transfer this patient to. When you're going to operate upon the patient, apart from the 34 to 36 weeks recommendations, I'm here later 36 to 38 weeks, I may say, because of the NICU facilities over here. But if the patient suffers from any accidental or severe bleeding, she may need an earlier intervention, whether regional or general anesthesia, whether you're going to use intravenous tranexamic acid or not. Surgery should be in the method you know how to do best. If you know how to do conservative management, it's going to be fine. But if it's not your expertise, and if you did not do this procedure before, please do not try to separate the placenta in a placenta accreta spectrum, because the patient's going to bleed severely and you not have the expertise or the facilities that's going to save the life of the patient. Give or not uterotonic drugs, the balloon, intra-balloon, internal iliac balloon occlusion, it's not recommended nowadays because it increases the blood going to the external and the new vascularized vessels, so the balloon is not recommended. The focal central disease or the wedge resection may be a possible option. To sum it up, proper diagnosis. This is very important. Put a line of management between 28 and 32 weeks in order to diagnose the cases. Early referral to a multidisciplinary team. In case of undiagnosed cases, don't hesitate to reclose the patient and refer her. If delivery is an emergency, either for fetal distress or severe antepartum hemorrhage, deliver the fetus and leave the placenta in situ. As I told you, the patient who the doctor called me at 5 a.m., he closed the uterus and left the placenta in situ. And 2 weeks after it, the patient came to our unit, and I did a suction evacuation for the patient, and we managed to conserve the uterus in this condition. Always keep the context of a team for emergencies. Telemedicine may be life-saving. Thank you very much.
شكرا للاخ الفاضل الاستاذ الدكتور وليد بسوني. الحقيقه الريكومنديشنز بتاعتك اللي هي اخر سلايد هي دي الحكمه اللي احنا لازم نلتزم بيها. اولا احنا لازم نبقى داخلين على العيانه انتسيبيتنج كل الكومبليكيشنز اللي توقعها. الموبايل بتاعك ده لازم يكون عندك ايه في تيم ورك، زملائك كول فور هيلب when you are in the OR or before that. دخلت العيانة، شخصت العيانة، الترا ساوند دايجنوز صح من الأول، حط بلان بتاعك. لو كانت جايه لك ايمرجنسي او جايه لك بلان، انت لازم تتصرف صح. دخلت اوضه العمليات، لازم تبقى العمليات دي فيها مستشفى متكامله الخدمات، فيها بنك دم، فيها رعايه، فيها تخدير محترم، فيها مسالك، فيها جراحه، في كل التخصصات اللي انت عايزها، ومعاك باك اب بتليفوناتك تكلم واحد واثنين وثلاثه، وما فيش واحد يشتغل لوحده. رجائي رجائي رجائي، كول فور هيلب، اصرخ ونادي الحقوني انا عندي كذا كذا كذا. ما فيش واحد ما عندوش خبره يروح داخل في عيانه ديت ويتخض منها. الخضه دي في حد ذات الفوبيا دي بالكومبليكيشنز بتاعتها كتير قوي. كمان لما تيجي تشتغل في المستشفى لازم تبقى دخلت اوضه العمليات جاهز من قبل ما تفتح العيانه. رول عندك بلادرز 4 إلى 6، رول اوف 4 او رول اوف 6، 4 بلادر، 4 ألس، 4 جرين أربتاج أو الأكثر. دمك موجود، بلازما موجودة، كل الإمكانيات اللي هي الصح عندك. وأنت بتشتغل هدي أعصابك، تفتح بالطول تفتح بالعرض مش فارقة. وخلي بالك يبقى عندك بندق، شاش بندق يبقى جاهز عندك وأنت شغال. خلي بالك ما تلعبش البلاد فيسز ديت لأنها خطيرة جدا، حته حته. ولو في بليدنج ما تتخضش برضه. والسيكرت اوف سكسس كاتش ذا سيرفكس يا وليد، كاتش ذا سيرفكس هي المفتاح المعنى. طبعا احنا هنتكلم كتير، انا طبعا
ده بناء على طلب دكتور صبحي، يعني هقدم دكتور احمد حسين، استاذ امراض النساء والتوليد في كليه طب القاهره. هو الهيد بتاع التيم بتاع البلاسينتا اكريتا في القصر العيني، وهو ابن استاذنا الراحل دكتور محمود حسين. كنا كلنا بنذاكر بالكتاب بتاعه، يعني انا كنت بذاكر منه وسمعت. اتفضل دكتور احمد.
Okay, first I would like to thank the organizing committee for inviting me to this great meeting. But also special thanks for my dear friend Professor Walid Bassiouni for his an extraordinary presentation, who showed marvelous understanding of such a disease. So the real question in the past years, what about the current guidelines, the classifications for PASS, and what the purpose they are made for, and they are fit anymore for this? So we'll discuss what happened in this world over the past 5 years. In 2018, this is the first time that I met Professor Eric Gignot, and by that time in 2018, Eric was the lead developer of the FIGO classification and also was the lead developer of the Royal College guideline, who was published in September 2018. And the first time I met him, I just told him one thing, this will not work. So he was extremely surprised about why it's not working. I told him the classification is a descriptive classification and not a clinical one. It will not have a clinician, this number one. Number two, I'm afraid that the obstetrician will abuse this classification because they will understand it wrong, they will misunderstand it, and it will increase the literature with publications that unfortunately will have false patients, and this will increase the bias in the literature. And after 250 citations of the classification, I told him, what do you think right now? Because most of these citations, they rely on the V classification as placenta precreta. We'll discuss later why this is not right. And they correlated with what's called the routine pathological examination. And unfortunately, I don't understand in the world how come a routine pathological examination can diagnose the invasion of the trophoblastic disease. Especially there must be a specialized placental pathology. So I don't think that routine pathological examination can fit in these publications. And talking also about the guideline, he has a point of view and has a point of view. The guideline, especially the Royal College guideline, is well read by 50% of the world. And it's designed specifically for the UK. So when we take this guideline and apply it in Egypt, it will not work. And I will give you very few examples. The first example is that when you screen the patient at 18 to 20 weeks and you find a patient with repeat cesarean section and low-lying placenta, refer her to what's called placenta accreta spectrum specialist. We don't have this job in Egypt. So what happened in Egypt over the past 6 years is that any maternal-fetal specialist with an ultrasound machine with color Doppler consider himself a placenta accreta spectrum specialist. And this leads to overdiagnosis, not in Egypt alone, in Latin America, Indonesia, and a lot of countries. The second thing is that the MDT in the United States, in the UK, is the chief surgeon, is a gyne-onc. And this is not the case in most of the countries that have a high volume of cases. The chief surgeon is a well-trained obstetrician, so it will not work. And the third thing is about the resources that they have and the MDT, which all these resources that also is not available in most of the countries with high volume. So I told him, this will not work. And then he told me, let's see, and this publication was in the American Journal 2019 about the prevalence and main outcome of placenta accreta spectrum. And what is in this publication was astonishing is that the incidence of placenta accreta over the literature varies from 5% to 50%. And the incidence of placenta accreta from placenta previa varies from 5% to 20%. So the disease that its incidence varies from 5% to 50%, it's not the problem of the disease. It's the problem of the people who are diagnosed with this disease. And that's why there was a major defect in the diagnosis of such a disease and definitely its management. So that's when we start to work together from 2018, and I think this is called the triad of success. You cannot have a proper surgical management without having a proper prenatal prediction surgical plan, and you cannot improve your sensitivity in the prenatal prediction surgical plan unless you have a proper pathological diagnosis to increase your sensitivity. So first we had to dig in the pathology, and this was our first publication. We worked with the team in King's, and it was very simple. We had the retrospective group of the King's College, and we do a very simple and effective, cost-effective method. If you do an hysterectomy, you cut the uterus into slices, you take each slice, try to do manual separation, and then get the slide from the area that's not separable. So if the placenta totally separated, then the job is done. You don't have a case. And if this case, this piece cannot be separated, then you fix the pathology from just. The problem with the pathology in the whole world is that you send to the pathologist the whole specimen, fix in formalin, and leave the pathologist to take pieces from anywhere he wants, and he has no understanding of the disease, unfortunately. So when you show the results, we find that in the King's group, they have a 30% of false positive. And the second thing, we have less number of slides, which means less cost. At the same time, both groups failed to show any patients that we have placenta or trophic chorionic villi outside the solar surface of the uterus. And in all our cases, we don't find a normal attachment of the placenta more than 30% of the placental surface area. So we dig a little deeper in the pathology, and to cut the long story short, we found that the real problem is not the placental pathology. It's uterine pathology. When you have scarification and uterine remodeling and the placenta becomes adherent to the myometrium, there is a high velocity vessels that allow for more fibrin deposition around the chorionic villi with the myometrium, and this is the cause that keep the placenta abnormally attached and cannot be detached from the myometrium, rather than an invasive disorder of the placenta. And this was a game changer, not for us, but for many countries, about let's search for what's so-called the entity placenta accreta, which means chorionic villi outside the solar surface of the bladder. We did a combined cohort study and systematic review. It was very simple and effective, using our pathology with the specialized placental pathologists here in the UK. We had 101 cases, and unfortunately, these cases, which are placenta previa and the placenta totally separated, are similar images in 80% of the literature that shows placenta accreta. If you look to the literature and the images, it seems like this. And all these 10 cases, the placenta totally separated. So we had our 101 cases, and we sent it to 2 FIGO experts who did the clinical classification, blind of the outcome. And unfortunately, they have 50% of our cases, they classify it as FIGO grade 3, which is placenta accreta. And no histological confirmation, because all our cases show nothing of trophoblastic outside the serosa. And from these 50 cases of the cases that the FIGO expert chooses as the grade 3, the placenta totally separated from them, which means that this classification cannot work anymore. 50%. And we did the systematic review. We looked to every single paper with an ultrasound, a pathology slide, and a gross image through the literature to search for the placenta percreta. And even the slides show placenta percreta by the authors. But these all was revised by Jonathan Hecht, who's the lead placental pathologist of Harvard. And unfortunately, he failed to prove any of them of trophoblastic cells that migrate outside the serosal cells of the uterus. So none of these publications, even if the authors say that it's placenta percreta, but when they revised by the expert placental pathologist, none of them showed any invasion outside the uterus. So because this was a game changer, and because this may cause some confusion in the literature, we have received about 10 letters to the editors about this publication, and we answered them in just only 2, that it's time to close this Pandora box that opened by Luke in 1966, and it was an idea. And how the whole world was following this about the invasive disorder of the placenta, and about the placenta can migrate anywhere, and this is a myth that must end. So people at that time, they don't know that we don't work alone, and we share our idea of different centers in the world. And the Utah Center of Brett Anderson and Robert Surfer, they worked over this topic over the past 2 years, and they published the results in the Green Journal in 2023, and they reached the same conclusion, but they write it in a very decent way. So I just need to point number 4, when they said that PAS does not typically invade beyond the serosa in situ. The complex surgical dissection of adhesions to the disease or perhaps uterine rupture can create a defect that the pathologist will look like placental invasion. So it's not the placental problem, it's a surgical problem. So when there is an adhesion, increased vascularity, and you go to the wrong plane, and then you send this, even the hysterectomy specimen with a part of the bladder, you send it to the pathologist, you get the same result, but when a specialized placental pathologist looked at it, he found the bladder, dense fibrosis, and the placenta with no chorionic villi traversing to the serosa of the bladder, and they reached the same conclusion about, they suggest that the PAS severity is likely mediated by scar dehiscence and uterine remodeling, no placental invasion, and this challenged the existing in situ invasive percreta as currently described. And then we move to the next level of ultrasound. And the whole world from 2015 is following the European Working Group criteria, which was proposed in 2015, about everything, the sonolucent zone absent, the thinning of the myometrium, placental bulge, lacunae, and all this stuff. But if you can see, this was an editorial. So the European Working Group, they never validate their criteria. They just group of people, sit in a closed room, and then put this criteria without any validation. So we worked hard on this validation, and we had trying to validate this, and we found that most of this sign occurs secondary uterine remodeling and scarification, because if you don't have a wall, if it's just replaced by a fibrous capsule, then definitely placenta by its weight will bulge. And definitely there is no myometrium, so it will be less than 1 millimeter. And definitely you will find absence of sonolucent zone. So all these criteria are not related to placenta accreta, they're related to what's so-called uterine dehiscence, and the placenta was implanted on this defect. So we cannot rely on these signs. And all these images, you cannot call it as placenta accreta, they're just complex cesarean section. So we need to have more standardized ultrasound signs. And then the International Society of Ultrasound chose a group of people, and I'm honored to be one of them, and we recruited 35 expert sonographers from different parts of the world, confirming the Delphi consensus expert panel, and we used the Delphi method through different rounds of questionnaires to reach a certain level of agreement for the signs. And we agreed on 7 signs with high agreement only on 3 on prediction of placenta accreta, which means lacunae more than 3 with lacunae feeding vessels, absence of sonolucent zone with presence of myometrium more than 2 millimeter, and high vascularity across the placental myometrial bladder interface. But the most important thing is our conclusion of this disease, that placenta accreta spectrum is not a sonographic diagnosis, it's a clinical pathological diagnosis. You just say high or low probability. And the recent signs need further evaluation before establish that are use or not. And the most important thing, that transvaginal ultrasound must be a part of the prenatal evaluation, not on placenta localization, but also in the prediction and of the surgical outcome. And I know the problem in the United States and the UK about the training of the veterinary specialists to do a transvaginal ultrasound. So we had our publication about the use of transvaginal ultrasound, and we find that both transvaginal and transabdominal have the same sensitivity in prediction of placenta accreta spectrum, but the transvaginal ultrasound had 5 more sensitivity in prediction on need of hysterectomy and blood loss. And we find that if you have a cutoff value of myometrium, what's so-called residual myometrium in the lower part of the uterine segment of 1 centimeter length, 2 millimeter or more width, this gives us a good chance for successful conservative management. So what are the keynote findings of all our publications in the past 5 years? Placenta accreta spectrum is not a diagnosis, it's the name of the family. If the placenta is separated, whatever ultrasound signs, intraoperative criteria you see, it's not a placenta accreta. There is no focal or partial total accreta. Abnormal placental attachment occurred secondary to uterine scarification remodeling. And placenta percreta, the concept outside the body of the uterus to invade the surrounding structure, never exists and was misconception by the surgeon due surgical manipulation. And PASS is not a steganographic diagnosis. You just say high or low probability. And in these 2 expert opinions, we tried to sum up everything, and we can say in one statement, it's not a game of invasion anymore. It's a game of placenta localization, vascularity, and adhesions. So last year, we had a workshop about placenta accreta spectrum, and I was honored to invite one of my dear colleagues. And we had to work live surgeries for 3 cases. One of them abnormal attachment, I did the focal myometric resection. Another one with dehiscence of lower uterine segment, and we did uterine sparing surgery. And the third one was a placenta previa with extensive adhesion between the bladder and the lower uterine segment. It took much, much more time, and it took much, much more blood inside the procedure rather than the other 2 cases. And this makes us realize that the placenta accreta is not the sole determinant of the complexity of the surgery. And there are a lot of factors regarding the placenta accreta that determine the complexity of the surgery. So if you can see, this is the plan of surgery that we have, and I think that nobody can do more than that. The type of surgery, disc and incision, trine incision, the bladder dissection. But the question is, and this what we need to answer in the next years, how to choose. So the choice of surgical plan is not depending totally on the patient's difficulty. It also depends on the surgical experience and the availability of the resources. So the same patient can be done in 2 different ways according to the surgical experience and the availability of resources to reach our primary objective, which is reducing maternal mortality and morbidity. So work hard on what's called the prenatal assessment of the complexity of the surgery beyond the placenta accreta spectrum. And we proposed a classification about the complexity of the surgery based on the number of cesarean sections, the thickness of the uterine segment, the placenta localization, and the vascularity. And this will not only help the patients, but also will help in the triaging of them to reduce the load on the centers of excellency and also to help in the training. And then we had an opinion that we published that forget about the histopathology, this is not related to the clinical outcome. Every lady has the right to do uterine sparing surgery, and the hysterectomy is done only in 2 cases, either the failure of reconstruction or the massive hemorrhage, and this will depend on the patient's difficulty and the surgeon experience. And as you can see, you need to expose the disease segment, deal with it, remove it, devascularize, and then you had the resected segment. If it is not attached, then in the case of normal attachment, no need to do histopathology in our countries, but if the placenta is separated, then this is not the case of placenta accreta. So we need first to stop searching for more signs of placenta accreta because this is useless. And we had our publication about the relation of placenta accreta spectrum signs with the surgical outcome, and we found a poor correlation with most of signs of the surgical outcome, so we need to stop looking for more signs. And we need to correlate the ultrasound signs to the surgical outcome. We need also to integrate the ultrasound with the intraoperative criteria to reach the better surgical outcome. And also we did this, and we found that combining the ultrasound, the intraoperative criteria, increase our awareness and give us prediction of the need of hysterectomy and blood transfusion or the need of an MDT. And this is the only way that we're going to achieve our goal in reducing maternal mortality and morbidity, number 1. And also to triage the patient to see that the more difficult cases go to the centers of excellency and the less difficult cases can be done by obstetrician, and this will decrease the load on countries that have high number of cases and also will help in the training of younger generation. So the real question is, what is the next step after all this academic lecture? Because this is not helping the clinician in performing what they say. So number 1, the guidelines. And I was honored to be one of the lead developer of the new Royal College Guideline. We started to work on it 2 months ago. We will finish by the by the mid of next year. And also we are working on another surgical classification that will not be descriptive. It must help the obstetrician to tell him what to do, but the classification will take a longer time because it needs to be approved by different societies from different countries to be universally used. And also we need to have a standardized protocol of management for low middle income countries, and we have worked on it, and I think it will be published by the end of this year, because this is the only way that we can be clinically oriented to answer the following: who will do it, when he will do it, and what to do. This is all the guideline, the classification, and the protocols must answer. It's not about saying that I have the better technique and this guy is doing 100% conservative, this guy is doing 100% hysterectomy. We need to understand through the guideline and the classification and the protocols to answer this question, so they must be more like clinically oriented. And at the end, I want to thank my team for their tremendous effort throughout this year, and my co-workers and dear colleagues from different parts of the globe for working together hardly over the past 5 years, trying to improving the quality of research and the quality of management of such a disease. And thank you all for attending.
الحقيقة يعني خالص الشكر والتقدير للأستاذ الدكتور أحمد بيه على هذه المحاضرة الجميلة الوافية. والحقيقة أنت بتشدني لمعلومة أنا ممكن آخد دقيقة واحدة أقولها بس. كان عندي من حوالي أسبوعين، والدكتور وليد بسوني عارف الكلام ده، عيانة جاية بالطيارة بارا 6 سيزيريان سيكشن 37 ويكس أو 36 ويكس تقريبا، دايابيتك هايبرتنسيف. أنا ما شفتهاش، أول مرة أشوفها في حياتي. فكلموني كان يوم الثلاث بالليل، قلت لهم تطلع أقرب مستشفى بس أنا عايز سونار ألترا ساوند الأول نعرف إيه اللي عندها. الحقيقة الأستاذ الدكتورة منيرة علي يعني كتر ألف خيرها، عملت لها ألترا ساوند بيرفكت. تلميذة الأستاذ الدكتور حاتم موسى. طبعا الناس دي بتعمل سونار صح، رسمة السونار للعيانة فين البلاسينتا، في الليفت سايد، في البروديجامنت، يعني خط سيرها واضح جدا. دخلت المستشفى العيانة يعني بعد الظهر الساعة تقريبا 5 مساء، وأنا كنت في هذا الوقت محتار أعمل إيه. طبعا أنا معايا تليفون وليد بسيوني، أكلمه ما أكلموش، المهم يعني إيه، دكتور التخدير قال لي مش هنشتغل إلا إذا جبنا 4 وحدات بلاد و4 بلازما ونحضر السرير رعاية وكل حاجة. قلت له أنا تحت أمرك. قعدنا نشرب الشاي والقهوة لما توفرت الخدمات دي كلها. المهم اشتغلنا والحمد لله تم يعني بحمد ربنا، والعينة عادت كويس وروحت بالسلامة إن شاء الله. هي كان أهم حاجة بالعين قعدت نص ساعة مش عايزة أشيل الرحم ده. بارا 6 سيكشن، هم دول يعشقوا الولادة. دي قصة من القصص الواحد ما ينساهاش. لكن في هذا قبلها بيوم واحد بالظبط كان معايا زميل جاي من انجلترا يزور اسمه محمد خالد الهضيبي. محمد خالد الهضيبي ابن الاستاذ الدكتور خالد الهضيبي، تشتغل في يوكي. هو ماسك حاليا تيم بلاسينتا اكريتا او بيركريتا في المنطقه دي. عندهم عيانه 41 سنه 130 كيلو جرام بارا 1 سيزيريان سيكشن، والعيانه دي البيبي ده الاولاني عنده مشاكل صحيه ونفسيه. شي جوت بريجننت، شخصوا البلاسينتا بتاعتها في الاسبوع تقريبا ما بين 11 الى 14 and they confirmed انها بلاسينتا اكريتا. they counseled her انها to terminate pregnancy. she refused completely. طب يا مدام يا ست الكل ما فيش فايده، ماشي. وفي الاسبوع 18 جالها اتاك وبليدنج، هي ساكنه قريب من المستشفى، اتنقلت المستشفى فورا وقالوا قرار ننهي الحمل ده. العينه بتنزف جامد والبلاسينتا داخله على البلادر وول. she refused to remove the uterus ولا حتى تفتح. فالمهم بعد ما اقنعوها كان في طبعا الاستاذ الدكتور شريف عبد الفتاح والدكتور حاتم موسى والزملائنا في انجلترا دول بيجتمعوا كل اسبوع وكل يوم كلموهم معاهم برضو دكتورة الأطفال، قال لك 18 أسبوع ده العيل ده ملوش وجود خالص وإحنا داخلين نشيل الرحم ده. هي رفضت، بعدين أقنعوها هي وجوزها to sign for hysterectomy أو termination pregnancy، غالبا hysterectomy. دخلوا قال لك فتحنا يا بيه لقينا الدنيا كويسة، بلاسنتا بري اكريتا والبلاد فيزلز جميلة، لكن مفيش انترنال بليدنج، واليوترس ده قعدنا بقول ما اعرفش طبعا ايه التست اللي عمله ده، لقينا ان هو ممكن يستحمل يعني ما يحصلوش رابشر. طب نعمل ايه؟ نعمل ايه؟ قال لك ايه؟ والله يا انا محمد قال انا مش هشيله، مش هفتح، مش هشيلها، هقفل بطنها. وهم اتفقوا مع بعض واتكلموا يعني احد من الزملاء and they closed the abdomen في الاسبوع 18. كانت مفاجاه للمريضه ولاهل جوزها انها ايه الرحم ده ما اتفتحش ولا اتشال. هي ساكنه قريب من المستشفى، قالك تبقى ان بيشنت قاعده لما تولد. طبعا الكلام ده رساله لزملائنا في كل مستشفيات جمهوريه مصر العربيه، بلاسنتا اكريتا اي وقت تجي لك دخلها المستشفى لما تولد، مفيش حاجه اسمها تروح البيت خالص ولا اقرب حته، لازم عندناش امكانيات. المهم يعني العينه ديت وصلت الاسبوع 30 بيتابعوا حالتها، كل شويه يجي لها شويه مغص، يخافوا يدخلوها، تقعد يومين ثلاثه تقول لهم انا عايز اروح تو كير ماي بيبي. وصلت الاسبوع ال 32 33 كان المشكله يوم ترمينيت ناو توداي، فادوها الدكسه، ومحمد ده سافر انجلترا وكلمني من اسبوع قال لي العيانه وصلت 34 اسبوع، جبنا بيبي 2 كيلو ونص تقريبا وما دخلش المحضن، والست دي علمتنا درس كويس جدا. انا بشكركم جميعا لان الحاله ديت غلسه شويه. طبعا الان يعني الصعيد والجنوب لازم ناخذ رايهم في الحالات دي. الاستاذ الدكتور سعد الجيلاني يقدم لنا معلومه مهمه جدا. The past disorder difficult endeavor with the paradigm shift in Upper Egypt. الدكتور وليد بسيوني قال اي حاجه جميله قوي، قال الان احنا الانسيدنس من 1 ل 150، يعني تقريبا هنخبط في القيصريات البرسنت ديت يعني كل تقريبا اسبوع على 2، وده حقيقي دي النسبه دي عاليه جدا. الان بيقول لنا ان هو الامكانيات تكونزيرف احسن منكم الامكانيات تو ريموف، لتوافر الخدمات والفريق اللي هو المتخصص في كل وحدات المستشفى عندنا في الدمرداش، كل وحده فيها فريق بيشتغل بلاسنتا اكريتا، وكمان في كل المستشفيات تقريبا في القاهره، اسكندريه، اسيوط، يعني في كل الاماكن في توافر خدمات، واللي ما عندوش هذه الخدمات ينقل المريض لاقرب مستشفى. استاذ الفاضل دكتور سعد بيه اتفضل ادينا المحاضره بتاعتك.
شكرا جزيلا. السلام عليكم. My talk about the past disorders with a special concern in Upper Egypt. ممكن اسال الحاضرين من صعيدي في موجود يرفع ايده؟ طب يعني 50-50. First, I have to thank and congratulate the scientific committee for invitation and for the this meeting. There is no conflict of interest. My talk is a little bit different from Dr. Walid and Dr. Ahmed. يعني ال traditional talks about diagnosis and management. أنا هاخدكم لحتة مختلفة شوية وهي البراكتس بتاعنا، وتحديدا في الكوميونتي بتاعتي أنا اللي هي الأبر ايجيبت. This is my agenda. البوبوليشن and size, the challenges of obstetrics in low resource setting, the challenges in managing PSC disorders, and especially in Upper Egypt, many experience and paradigm shift efforts by the Upper Egypt universities. This is the map في Egypt. دي خريطة مصر طبعا زي ما حضراتكم شايفين، وده مساحة الصعيد، يعني تقريبا شايفين المساحة والأطراف المترامية لصعيد مصر. لو حضراتكم شفتوا تعداد السكان في صعيد مصر تقريبا 36 مليون، وده بيمثل تقريبا 40% من سكان مصر، يعني تقريبا 40% من قربنا على النص. يعني دي مساحات محافظات الصعيد بداية من الجيزة ولحد الأقصر بترتيب عدد السكان. فحضراتكم شايفين يعني تعداد مهول جدا. كل محافظه من المحافظات تقريبا ممكن يبقى تعداد دوله من الدول او اكتر كمان من الدول. في دراسه اتعملت في المنيا عندنا طبعا تقريبا ماشيه مع الاحصائيات العالميه انه تقريبا 1% الانسيدنس اوف اكريتا، بغض النظر يعني على الدايليما اراوند دايجنوزيس والهيتروجينيسيتي اوف ذا كونديشن اوف ذا بلاسينتا اكريتا. ده مش طريق الصعيد، ده المفروض طريق ممهد. ايوه ده المفروض يكون طريق from conception to safe berberium. It is not soft or smooth like that, but it's filled with many gaps. وحضراتكم طبعا بتمارسوا في مصر وعارفين طبعا المشاكل اللي عندنا، بداية من inadequate إلى improper antenatal care و lack of skilled health care providers. الcorruptions in the referral system between the different health service providers ما بين العيادات والمستشفيات الجامعية ومستشفيات التأمين الصحي. وطبعا الدايليما حوالين الافيلابيلتي والريستريكشنز في البلاد بانك وخاصة في البريفري والاكسس تو اسينشال ميديسينز. كل دي مشاكل بتواجهنا في الاوبستيتريكس عموما. التريننج، اللاك اوف بروتوكولز، والمصيبه الكبيره عندنا طبعا البرايفت كلينكس والحاجات اللي بتحصل فيها، والديتا كولكشن والافيلابيلتي ولاك اوف اوديتنج وتيم وركينج، والاهم من كده البوليتيكال ويل ان انت تحسن المنظومه اللي موجوده. جلوبالي في مشاكل طبعا في البلاسينتا اكريتا سبيكترم، حتى في الديفينيشنز والانسيدنس والبريفالنس، نتيجه لحاجات كتيره الدكتور احمد لفت انتباهنا ليها. الابسنس اوف هاي كواليتي ايفيدنس، اللاك اوف ستاندرايزد ابروتش، الناس بتشخص كل واحد ليه امباكت معين في الدياجنوزيس، والهيتروجينيسيتي اوف افيلابل داتا. عندنا في الصعيد مشاكل اكتر من كده كمان بالاضافه للمشاكل الثانيه، وهي مشكله الجغرافيا. حضراتكم عارفين انه دكتور محمد في المنوفيه ودين 50 كيلو ممكن الف 3 4 محافظات، مش كده؟ انا عندي في المنيا 135 كيلو طول المحافظه، اسيوط نفس الكلام، سوهاج، فدادين متراميه، ودي طبعا اكيد هتعمل مشكله في ممارسه الاوبستيتريكس. الهاي باريتي، حضراتكم عارفين طبعا الصعايده مفيش 1 و2 و3 والكلام ده، يعني احنا يعني، والجندر مش هقول ديسكريمينيشن انما بريفرنسز، يعني ناس بتحب الولاد وناس بتحب برضه الولاد ما بيحبوش البنات. احنا عندنا في بلد في مغاغه تحديدا they are not counting الفيميلز، يعني تقول لها برا 6 دول ممكن يكون مثلا ان هي برا 11 برا 12 وال6 دول ميلز بس. يعني الهاي اوردر سيزيريان سيكشن، الريسورسز طبعا والكونزرفاتيف كوميونتي بتافكت، ولان الجغرافيا مش هي بس المكان ده، الناس والتعليم والثقافه والباك جراوند، وده كله بيرفلكتد على حضراتكم في الممارسه. ودايما بقول للطلبه دايما لازم تبقى عارف جغرافيه المكان اللي حضرتك بتشتغل فيه، عارف عادات الناس وتقاليدهم ايه. يعني ممكن السيده دي تيجي للدكتوره ما تجيليش انا وتكون حالتها خطر مثلا او المنيا المدينه الجميله دي لحضراتكم يمكن كتير حضراتكم شافها وما شافهاش. تخيلوا ان المدينه دي بطول 135 كيلو وعرض تقريبا 40 كيلو، فيها 1 تيرشري هوسبيتال اللي هي مستشفى المنيا الجامعي. يعني حضرتك لو موجود في النبطشيه ممكن يتشاط عليك حاله هاي ريسك بتنزف او بتفتس على بعد 50 60 كيلو في النبطشيه كل يوم بالحال ده. احنا طبعا في القاهره دلوقتي تخيل انت في محيطك 30 كيلو في حوالي 10 15 مستشفى تيرشري يقدروا يتعاملوا مع الحالات دي، وده هايلايتنج طبعا الايكواليتي والايكويتي في البروفايدنج الهيلث سيرفيس للناس اللي عايشه في الصعيد والناس اللي عايشه في سنترال. كانت لنا خبره في المنيا، احنا بدانا تقريبا في 2012 لما بدانا نشوف حالات الاكريتا كتير، فبدانا ويعني حبينا ننظم الكلام كايزوليتد كيسز، وبعدين بدانا نعمل بروتوكول، ومع تجميعة الحالات بدانا الكولكت الداتا ونعمل بابليكيشن، اند فاينالي now we in the stage of serving the community regarding this issue. The first isolated case دي كانت سنة 2012 ودي كانت intraoperative surprise، كانت para force cesarean section و intraoperative diagnosis. وطبعا دي كانت أول حالة إن إحنا to be diagnosed with placenta accreta أو recorded يعني. يعني دي أول حالة عملنا فيها cutting the cord short and then we left the placenta and completely resolved it after 2 months. The second stage عملنا بروتوكول في مستشفى المنيا الجامعي. It wasn't different from the international ones. ويعني in the form of the first option cesarean hysterectomy if we diagnosed. The second option is to conserve if in certain indications ست low parity, refusing to do cesarean hysterectomy أو difficult radical surgery. And the third option اللي هو leaving the placenta وده طبعا سنة 2013. يعني احنا دلوقتي moved on this stages now. The first trial registered on this issue published in 2015 cervix as a natural tamponade to control the intraoperative bleeding and was cited تقريبا 38 مرة and mentioned in the FIGO guidelines and RCOG and presented in Vancouver in 2015. And this is another study about the management of accreta using cervical tamponade and uterine ligation. In addition, من 2016 تقريبا لحد 2022 بدأنا نعمل yearly thesis, master and MD thesis to collect the cases from January to December. كل الحالات اللي تيجي مستشفى الجامعة نسجلها، وطبعا عشان نضمن الاستمرارية في العمل كان طالب أو كانديديت يسلم كانديديت عشان يبقى عندنا إحصائيات من 2015 لحد دلوقتي. وزي ما حضراتكم أكاديميين وعارفين دي الطريقة البسيطة اللي احنا ممكن نضمن إن العمل يتسجل ويبقى بابلش بعد كده. الستيج اللي بعد كده كانت ستيج الكوميونتي، وده طبعا الومن هيلث is not responsibility of universities only. It's the university is the responsibility of Ministry of Health, الهيلث كير بروفايدرز اللي بيشتغلوا في العيادات وفي المراكز وفي المستشفيات الجامعيه والانشورنس وكل الناس. فبدانا في 2015 وبالتعاون مع دكتور احمد جلال في جامعه اسكندريه ان احنا نطبق برنامج اسمه امان بروجرام. وده كان فكرته ان احنا نعمل اويرنس للهيلث كير بروفايدرز على حاجات فيري سيمبل، ازاي تشخص البلاسينتا اكريتا او البلاسينتا بريفيا، ازاي تكنترول الهايبرتنشن. وده اتطبق في الدلتا وفي مطروح وفي الصعيد وفي المنيا تحديدا. ودي كانت جزء من الورك شوبز اللي احنا بدانا نلف بيها على المستشفيات، ان احنا بنحاول الهيلث كير بروفايدرز ان هم يفيسنج الدينجرس سيتويشنز. من استفادتنا بالتيلي ميديسين زي ما قال الدكتور وليد والسوشيال ميديا، كنا بنعمل جروبات زي ما حضراتكم عارفين طبعا على الواتس جروب، وكان ليه امباكت طبعا على السيفنج ماتيرنيتيز. وحضراتكم شفتوا في كذا ميتنج انه ناس زمايلنا البيجنرز او الجينيورز فتحوا حالات وكانوا قلقانين من الفيلد اللي لما شافوه. كنا بنسال الزملاء ان هم تو واتس ذا ايمج على الجروب، وكان في حالات كتير بتتقفل وتتحول وتتفتح في مستشفيات الجامعيه. طبعا اللي بيشتغل في الاوبستيتريكس او العمل المجتمعي لا يسلم من الاذى سواء من المحيطين او من الناس. فحصل كونفليكت اوف انترست في 2019 في برنامج امان، توقف تماما طبعا في الجامعه ونتيجه لاسباب يعني شخصيه. بعد كده اضطرينا ان احنا ولان احنا بنؤمن بفكره خدمه المجتمع ان احنا نفكر بره الصندوق ونطلع بالشغل. يعني لو ان الجامعه مش الشغل المكان الوحيد اللي انت ممكن تشتغل فيه وتخدم الناس، بدانا نعمل اشهار لمؤسسه امان، ودي لشؤون المرأة طبعا، ودي كان مقرها محافظة المنيا، وكان الهدف الأساسي ليها السيف ماذر هود. ومن الحالات طبعا اللي ريكوردت في سنة 2019 حالة واحد زميلنا دكتور يوسف تقريبا 30 years كان لسه واخد الماستر، فتح الحالة ولقاها بالمنظر ده. قلنا له صور الحاله فصورها، قلنا له اقفل وبعدين هاتها لنا مستشفى الجامعه. ده كان من ضمن الحاجات اللي هي السكسسفول ستوري للكلام ده. طبعا دي كانت خبرتنا في المنيا. جنبينا طبعا الجامعه الام المحافظات الصعيد جامعه اسيوط، الدكتور علي السمان والدكتور كمال زهران والدكتور مصطفى السنباطي والدكتور ضياء طبعا واساتذتنا في جامعه اسيوط بيبذلوا مجهود عظيم جدا. وهي محافظه اسيوط على الرغم ان تعداد السكان طبعا تقريبا 5 مليون، انما هي اكشوالي هي بتخدم الصعيد كله يعني، لان هي الجامعه الام. وزي ما حضراتكم شايفين برضو زي المنيا بالظبط، هي محافظه طوليه تقريبا 100 كيلو او 100 وحاجه، فطبعا الحاجات كلها بتحدف عليهم من كل حته. ده الورك لود اللي كان عندهم في خلال فتره معينه. هم بيستخدموا تكنيك معين، ريسكشن اوف ذا لور سيجمنت، دكتور علي السمان، دكتور كمال زهران الباوتش تكنيك اند يوتراين ارتري لايجيشن، ودي سامبل من الببليكيشنز بتاعتهم. اشهر حاجه طبعا بيعملوها اليوم العلمي اللي محافظين عليه من 5 سنين على البلاسينتا اكريتا، وبيعملوه انيولي تقريبا من 2017 تقريبا. محافظه سوهاج بتخدم حوالي 5.5 مليون، وهي محافظه طوليه برضو، وليهم اكتيفيتيز وببليكيشنز، وده جزء من الورك لود عندهم. ودي سامبل من الببليكيشن اللي نشرها الدكتور مجدي عبد الرحمن على الديفرنت تكنيكس تو كونزيرف. والحقيقه ان محافظه سوهاج عندهم يعني اميل للكونزرفيشن من الراديكال سيرجري، وده شفناه في ورشه عمل كانت جميله جدا على مدار يومين في شهر 8 اللي فات، وكان حاضر معانا الدكتور احمد حسين. ساوث فالي يونيفرسيتي طبعا اللي هي محافظه قنا، دي بتخدم حوالي 3.5 مليون، وعندهم برضو التكنيك اللي هم بيشتغلوا بيه دكتور محمد عبد الرحمن والدكتور مصطفى خضري، internal iliac ligation and extensive bladder dissection to conserve the uterus. وليهم lot of publication طبعا. اتجاه جنوبا لأسوان بتخدم 1.5 مليون، انما هم المساحه الجغرافيه لأسوان لحد ابي سمبل طبعا، ودي مساحه كبيره جدا. عندهم different techniques conservation in the form of pouch, internal iliac ligation, one step conservative surgery and transverse B-Lynch. وعندهم حقيقه a lot of publication في المانجمنت اوف بلاسينتا اكريتا. لوكسور جفرنريت 1.3 مليون، طبعا هي جامعه لسه ناشئه، وهم طبعا اللود بتاع الحالات بتاعت الاقصر طبعا يتجه جنوبا لاسوان، يتجه شمالا لقنا واسيوط، لان مستشفى الجامعه تقريبا لحد دلوقتي اللود كله يعني تقريبا اعتقد ان هي ما بتشتغلش لحد دلوقتي. الفيوم وبني سويف طبعا محظوظين شويه عننا، لانه ساعه زمن من الفيوم وبني سويف بيرموا حالاتهم على حبايبنا في عين شمس والقاهره والازهر. وان كان اللود في الفيوم وبني سويف تقريبا اللي انا عرفته من الزملاء ان هم مقسمين الاسبوع الى 3 ايام و3 ايام امرجنسي، ففي حالات بتروح القاهره وحالات بتروح عين شمس والازهر والبرايفت سيكتور. وان كان مدينه الفيوم او جامعه الفيوم بدات باول عمل منظم، وغريب ان وعلى فكره الفيوم الجغرافيا بتاعتها قريبه من جغرافيه الدلتا لان هي محافظه دائريه، وكانوا مميزين جدا في اول ورشه عمل منظمه طبعا اتعملت في 2022، وكان الدكتور احمد حسين والدكتور علي السمان وزميل الدكتور احمد ربيع في سنه شهر 12 السنه اللي فاتت، واشتغلنا حالات لايف في المستشفى الجامعه. بني سويف زي ما حضراتكم سمعتوا من ضمن الكولابريشن اللي اتعمل في محافظات الصعيد ان احنا جمعنا كل الناس الاكسبرت اللي بيشتغلوا حالات اكريتا وعملنا الباس اب كولابريتيف جروب، بندردش مع بعض، بنشوف كل واحد بيشتغل ايه، بنشوف الديفرنت تكنيكس والورك لود في كل جامعه. وطبعا مؤسسه امان بدات دلوقتي من حوالي 2 أو 1.5 سنة ان احنا نعمل اكسترا يونيفرسيتي اكتيفيتيز زي اويرنس. حتى احنا بدانا بروجكت من حوالي 2 شهرين بنعمل اويرنس لحاجه اسمها الرائدات الريفيات، يعني تسال الست انت عندك قيصريه واحده ولا قيصرتين، لازم تسال الدكتور اللي بيعالجك المشيمه تحت ولا فوق وملتصقه ولا مش ملتصقه، يعني وعي اكتر للرائدات اللي هم بيدخلوا كل بيت. ده طبعا جوجل فورم بنجمع عليه حالات الاكريتا، وده مفتوح لكل الناس في الصعيد، بنجمع عليه الحالات على امل يعني ان احنا يبقى عندنا الكابابيلتي ان احنا نببلش الشغل بتاعنا، لانه كل مكان من الاماكن دي عنده ورك لود رهيب جدا. وده طبعا كل الافورتس اللي اتعمل في خلال ال10 سنين اللي فاتت دي ادى الى طبعا الحمد لله انه الاويرنس زاد بالمشكله، وحضراتكم عارفين الكلام ده، مش بس among الهيلث كير بروفايدرز but among البيشنت. الترياجينج تو ذا سنتر اوف اكسلنسز، احنا يعني في المنيا تحديدا الحمد لله ما فيش حاله من حالات الاكريتا اللي هي بتبقى سسبكتد او دايجنوزد بتتفتح لا في برايفت سيكتور ولا في مستشفى بعيده عن المستشفى الجامعه، لانه ده المكان اللي يقدر يتعامل مع الحالات. الحاجه اللي بعد كده التريننج، ان احنا كل شويه بنعمل تريننج للناس سواء لايف او سواء في ورش عمل. المالتي سنتر كولابريشن ما بين الجامعات وبعضيها، الاوديتنج للافكتس بتاعتنا، والريسيرش والببليكيشن زي ما حضراتكم عرفتوا او شفتوا. وفي النهايه ان احنا يهمنا الامبروفينج اوف ذا اوتكم. I have to acknowledge my colleagues especially in many university and my professors research team and thank you.
شكرا للاخ الفاضل الاستاذ الدكتور سعد بيه الجيلاني على هذه المحاضره العميقه، واشكرك على الصور الجغرافيه للمحافظات كلها والجامعات الجميله، وده نوع من الدوكيومنتيشن، واحنا لنا برضو معلومه نستفيد نعرف ازاي نسجل حالاتنا وازاي نجمعها وننشرها. ونشر الحالات دي مهم جدا جدا جدا. اوعى واحد منكم يتكسف يكتب اللي حصل معاه، سواء في التشخيص إذا في مشكلة أو في الإمكانيات لو في مشكلة أو المضاعفات لو في مشكلة. المعلومات مهم جدا نتبادلها مع بعض كجامعات، كمراكز، كفرق عمل، سواء داخل مصر أو مع زملائنا في إنجلترا. كلهم الحقيقة متعاونين معنا بصورة إيجابية، وهم كلهم في المؤتمر النهارده عندنا بيسعدونا سعادة جامدة. شكرا أستاذنا الفاضل على هذه المحاضرة الجميلة. شكرا.
السلام عليكم. مبدئيا بنشكر الاورجنايزنج كوميتي على المؤتمر الرائع ده، والحق يتقال يعني مجهود اكثر، وده اللي متعودين دايما في طب عين شمس. كل الاستاف اللي شغالين فيها كل هدفهم انها تطلع بالصوره المشرفه الواحد شايفها دلوقتي. وبتشرف بان انا بقدم الاستاذه الدكتوره نوره هتكلمنا على الاي سي يو برنسبل اند مانجمنت اوف ميجر اوبستاتريك هيموريج. اتفضلي يا دكتور.
طبعا بدون اي سي يو العيانه تضيع منك. ما تشتغلش في مكان ما فيهوش وحده اي سي يو بامكانياتها الكامله المتكامله 24 ساعه ليل نهار صاحيين جنب المريضه بكل الاجهزه. اتفضل.
First of all, I would like to thank the scientific committee and the organizing committee for this invitation to this meeting. I'm Dr. Noura, lecturer of anesthesia, intensive care, and pain management. I'm also a member of the ICU unit in the Obstetric and Gynecological Hospital in Ain Shams University. Today we're going to talk about the ICU principle of management of major obstetric hemorrhage, which was previously stated as one of the nightmare of the obstetrician and of the intensivist also. Last year, we received around 150 cases suffering from obstetric hemorrhage and shock, with different complication and organ dysfunction and different outcomes that ranged from complete recovery up to mortality. For example, we have this case. It was 20-year-old patient presented to ER with postpartum hemorrhage and shock. Patient had a vaginal delivery the day before and immediately developed postpartum hemorrhage. Patient, there was attempts of control of bleeding, and they used iatrogenic drug, uterine massage, antifibrinotic drugs, even packed RBCs were given about 2 units. Unfortunately, hemorrhage was not controlled and patient was transferred to our hospital the next day. Patient came shocked, confused, blood pressure was about 60/30, heart rate more than 140 beats per minute. Patients were immediately rushed to the OR. Primary resuscitation were done with as long as a hysterectomy. Blood pressure, bleeding was successfully controlled. Patient received the MTB protocol, 4 packed RBCs, 4 fresh unit plasma, 12 units of platelets, 10 units of cryoprecipitate. Patient was transferred to the ICU, intubated, ventilated, on cardiovascular support. Despite control of bleeding, close monitoring, adequate supportive treatment, follow-up labs, correction of any abnormality, and transfusion of blood products accordingly, patients still develop DIC and organ failure. This is only one scenario that is repeated many times with the difference in some details. So, we knew from the previous lectures that most of the obstetric hemorrhage are preventable. So what affects the outcome of the patient? Why some are completely recovered and others can still have organ failure and mortality? Well, first thing is early proper intervention. As soon as we intervene and proper management according to guidelines, better the outcome. Multidisciplinary approach and the complexity of cases. Some cases are not straightforward hemorrhage. They have other hidden pathology. We should put it in mind in consideration. Obstetric hemorrhage is considered as blood loss more than 1,500 ml, or decrease in hemoglobin more than 4 grams per deciliter, or acute transfusion of more than 4 units per packed RBCs. Massive transfusion protocol should apply to any patient that require more than 4 units of packed RBCs in less than 4 hours, with or without hemodynamic instability, or with or without anticipated ongoing bleeding. Etiology of the obstetric hemorrhage can be summarized to the 4 T's. Management, regarding management. Immediate management of obstetric hemorrhage is the same regardless the cause. Successful hemorrhage is a teamwork. Once hemorrhage occurs, everyone should be alerted. Obstetrician, anesthetist, intensivist, hematologist, nephrologist, nurses, and porters. Through the teamwork, successful management will happen. So you should remember that hemorrhage is only a symptom. Diagnosis and definite treatment still should be initiated during the primary resuscitation. Primary resuscitation has 3 components. First of all, the hemostatic component, in which we stop the bleeding by identifying the source of bleeding and the appropriate management. Either uterine drugs, surgical intervention, or other maneuvers. Other components are the hemodynamic management, which our goal is to adequate tissue perfusion and maintain tissue oxygenation. So we immediately start patient on 100% oxygen through resuscitation. Our goal is to maintain an arterial pressure between 80 to 90, systolic blood pressure between 80 to 90 till control of bleeding. It also should advise to increase the use of norepinephrine early to maintain this arterial blood pressure. This will allow us to a low volume resuscitation protocol in which it decreases the dilution coagulopathy that comes from massive fluid resuscitation. The third component, the coagulation management. We start with tranexamic acid infusion and an antifibrinolytic dose 1 gram IV followed by 1 gram infusion over the 8 hours. We should send blood for cross-matching and for baseline for transfusion coagulation markers, CBC, PT, PTT, platelet, fibrinogen. Our target is to maintain the hemoglobin between 7 to 9, the PT, PTT 1.5 times their normal value, platelets about 50,000, and fibrinogen level more than 1.5 to 2 grams. We should start blood transfusion early as possible. Once we reach the massive obstetric hemorrhage, early administration of fresh frozen plasma and activate the massive blood transfusion protocol as soon as possible. Also, we should put in consideration our lethal triad. We should avoid the acidosis, hypothermia to avoid coagulopathy, and keep the calcium level between 1.1 and 1.3. There are many massive transfusion protocols. It may be 4 packed RBCs, 4 fresh unit plasma, and 1 dose platelets, which is about 6 units, or 4 packed RBCs, 4 fresh frozen plasma, and 1 dose of cryoprecipitated, about 10 units, or 10 to 1, 6 packed RBCs, 4 fresh frozen plasma, 10 cryoprecipitated, and 1 single dose of platelet, 10 units, 6 units. Whatever you pick, you should have one, simple one, and start it immediately once needed. This is a diagram about the MTP, sample of the MTP protocol. Once activated, we should withdraw baseline MTP panel, hemoglobin, hematocrit, and platelet, DIC panel, and ABG, and metabolite, calcium, and potassium. We start with the initial blood package of 4 fresh frozen plasma and 4 units of packed RBCs. Then we reassess if there is ongoing bleeding or not. If yes, we give another 4 units of packed RBCs, another 4 fresh frozen plasma, 6 units of platelets, 10 units of cryo, and repeat the empty panel. Then reassess bleeding. We should do reassessment of the bleeding and total ongoing losses. Once control the bleeding, we deactivate the MTP. Further transfusion will be according to the lab results. If INR is 1.5, we should give 2 units of fresh frozen plasma. If platelet count less than 100,000, we should give 6 units of platelets. If fibrinogen is less than 200 milligram per deciliter, we should give 1 dose of cryoprecipitated 10 units. What to do once bleeding stops? Well, we'll continue follow-up and frequent reassessment for fear that bleeding will recur. Repeat the MTP panel and give blood products accordingly. ABG to correct acidosis and correct any electrolyte abnormality. We should anticipate for complication and consider any other hidden pathologies. Anticipate complication. Most common complication will be the hypoperfusion injury from brain, heart, kidneys, pituitary necrosis, complication from blood transfusion, and infection. This summarizes the main complication of blood product transfusion. I will go through them rapidly. Well, most serious are the acute hemolytic reaction due to ABO incompatibility, graft versus host disease, transfusion-associated circulatory overload, and transfusion-related acute lung injury. Massive blood transfusion complication, the DIC, fibrinogen dysfunction, platelet dysfunction, hypocalcemia, hypercalcemia, and hypothermia. Regarding acute hemolytic reaction, this is a hemolysis of the donor or recipient RBCs during or after ABO transfusion. Most common cause will be from the ABO incompatibility, maybe also due to plasma antibodies or hemolyzed fragile RBCs during overwarming of the stored blood. Hemolytic reaction can be acute, occur within 24 hours, or maybe even delayed up to 1 to 14 days. Hemolysis will be intravascular, causing hemoglobinuria and causing varying degree of acute injury. Symptoms will be as abrupt discomfort and anxiety, dyspnea, fever, severe loin pain, and even shock. We have to put into consideration acute hemolytic reaction in patient under GA will only be evident as hypotension, uncontrolled bleeding from incision site caused by the associated DIC, and dark urine that reflect hemoglobinuria. Prognosis is determined by the degree of AKI. Usually, it's usually diuresis and decreasing bond usually favorable outcome. However, permanent renal insufficiency are unusual, but still can happen. Initial therapy will be to maintain blood pressure and renal blood flow. We're using IV saline and furosemides. You maintain urine output of more than 100 milliliters per hour for 24 hours. If pressure drug is necessary, we should use dobutamine and avoid other pressure drugs that may decrease the renal blood flow. As soon as acute hemolytic transfusion reaction happens, we should involve a nephrologist, as the patient may require hemodialysis if there was no diuretic responses within 2 to 3 hours. Transfusion-associated circulatory overload. These are unrecognized and underreported, but still they are the most common causes of deaths related to mortality, to transfusion-related mortality. This is made due to increase the osmotic load of blood products. They draw volume into the intravascular space of the course of hour, which cause circulatory overload. This happens in susceptible patients with cardiac and renal insufficiency. We can prevent it by using furosemides in this susceptible patient. TRALI. It's a self-limiting complication that happens from the anti-THLA, anti-granulocytes antibody in the donor plasma that agglutinate recipient granulocytes within the lung. Symptoms appear as tachypnea, hypoxia, and hypotension. Chest X-ray will reveal bilateral interstitial filtrates. It is more common with transfusion of platelets, then fresh frozen plasma, then packed RBCs. Treatment is usually supportive respiratory and hemodynamic therapy. It typically resolves without long-standing sequelae within 96 hours. Role of steroid is highly debated in TRALI. Last thing is to consider other ongoing pathology beside bleeding. The cases are not always straightforward. Many cases have 2 or 3 pathologies going aside. For example, in this case, we have a 80 years old paratus section with placenta accreta. She was admitted to our ICU post-operative after CS. Intraoperative, there was massive blood loss, about 3,000. Immediately resuscitated with warm fluid, norepinephrine infusion. MTP was initiated early. Bleeding was successfully controlled by hysterectomy. Patient received intraoperative total of 6 unit packed RBCs, 6 unit fresh frozen plasma, 6 units of platelet, 12 units of cryoprecipitate. The protocol was administered properly. Patient was transferred to ICU, intubated, ventilated, sedated. Vital data was 110 over 70 with over 200 nano per kg per minute norepinephrine. Heart rate was about 140. Space saturation was about 96. In ICU, resuscitation was continued according to our protocol and guided by CVP, urine output, and post-operative CBC coagulation profile. Patient then developed frothy secretion from the ET and chest auscultation in fine basal crepitation, indicating pulmonary edema. We first suspected TRALI according to the X-ray that shows bilateral interstitial infiltrates. Patient was managed accordingly and lung condition improved, but still there was evidence of pulmonary edema. And patient was still on cardiac support, norepinephrine. Blood pressure was about 90 to 110 over 50 and to 60. Heart rate was 110. We couldn't wean the patient from the ventilatory or cardiac support. So echocardiography was done and revealed dilated cardiomyopathy with an ejection fraction of 30%. Once inotrope were added in form of Wtrex infusion and other anti-failure measure, patient improved and was successfully weaned from respiratory and other cardiovascular support. This case reflects the complexity of our patient, in which we found 2 types of shock side by side, hemorrhagic shock and cardiogenic shock, and was successfully managed and discharged from the ICU. Any question? Thank you.
نشكر الدكتوره نورة على هذه المحاضره القيمه. والحق يتقال انتوا الملاذ الامن بتاعنا في الحالات اللي زي كده. هم ينزفوا العيانين واحنا نديهولهم. ربنا يديك الصحه.